Thank you for that very lovely and humbling introduction. I'm really not that good, but I'll do my best for you. So it's good to be back in New Zealand. I worked here 33 years ago in Christchurch when I went there for the ski season. Obviously I went there for clinical experience, but really I went for the ski season. And my now wife came to join me there as my girlfriend at the time, so it seemed to go pretty well. So thank you on behalf of both of us. So I'm going to talk to you a little bit about enhanced recovery and a little bit about hemodynamic management. Today is supported by Edwards Life Sciences, and I do consult for them. I'm not going to mention products, that's for you to decide what you buy, but I might mention some of their pipeline at the moment, because I am part of a team that's working with them in their headquarters in America on the use of artificial intelligence and closed loops to help the computers help us do a better job perioperatively, and it seems to be going quite well. I'm also going to mention my work at the Department of Health from May 2009 to March 2013, where I was a national clinical lead for the rapid spread and adoption of enhanced surgical recovery in the National Health Service. We went for total adoption. I'm the founding director of something called Evidence-Based Perioperative Medicine, and I know some of you in the room have been to some of our events globally. Our initial event, our first event, which is now 21 years old, is on the west coast of Ireland, very similar scenery to parts of around here, in a place called Dingle, which is where, those of you who are Star Wars fans, it's where they found Luke Skywalker. Because if you had all the power and the money in the world, you would go to the west coast of Ireland. Trust me. It's also a great meeting. We also have one in London every July, and now we have a global presence. This is a not-for-profit organisation. We have a meeting in Dallas, we have a meeting in Chicago, and in September of this year we're having our first meeting in Singapore. So if you'd like to come and join us, please do. If you can't physically come and join us, we are committed to carbon-friendly conferencing. So everything that comes off our stage now is broadcast live to the world completely free. So if you just log in, you can listen and or watch all of our lectures, and if you don't listen to it at the time, we have a podcasting channel, and every day of the week we put out a new podcast with one of our lectures or a conversation. And many of the things I'll talk about today, if you put them in the search engine of TOPMEDTALK Top Med Talk, you'll be able to get free those podcasts. So when you get a chance later, go into your phone, some people are doing it already, put in TOPMEDTALK. If you subscribe, there's no money required at all, it's completely free. We'll send you a podcast every day. If you go into our app that's in there, you can search Relief or Fedora or some of these trials I mentioned, and you can listen to an account of them. It's also really, really good if you're trying to go away and tell somebody that this crazy person from England came over and said you should do this wacky stuff, and they say, I don't believe you, you can make them listen to it, which is can be quite effective. So we were hoping to have 10,000 downloads in our first year, and it's been so popular. I'm checking today, we're up to about 200,000 downloads. This slide's about a week old, and we've been listened to in 130 countries around the world, and New Zealand is we're now top 5 listening countries. So for those of you who are already fans, thank you very much indeed. Right, I'm going to talk a little bit about surgical complications. This is some data from the United States of America, and the message here does seem to translate globally, and that is that complications after surgery, major complications, cause a lot of misery and cost a lot of money. Now I've chosen this example because it's from a place called Johns Hopkins University School of Medicine in Baltimore, Maryland, and that's a very shiny place where they've got loads of money and they think they're really, really good at this. So this is, you might think, as good as it gets. And they've looked here at the impact of major complications on the finances within their system. So I'm just going to concentrate here. This is elective colorectal surgery. I'm going to take away the DRGs, which is just going to distract us, and just concentrate on the right-hand column. So 821 patients, post-operative morbidity occurring in 28% of their patients. The median length of stay 8 days, with an interquartile range of 5 to 14. So in 2016, they're reporting that 25% of their patients are in hospital for more than 2 weeks, and more than a quarter of them are getting post-operative complications that are quite significant. With regards to their observed expected length of stay, they, by their own admission, are not very good at it. They get the predicted length of stay wrong by a day or more more than half the time. So they're not very good at predicting that, and that has consequences with bed allocation. It's also interesting to note that in their system, that 58% of patients go home, but 42% go somewhere else. So the real length of stay is even longer. They have a high use of these nursing facilities in the USA, so you can pretend that somebody's gone home, and you can report a length of stay of 5 days, whereas actually they're in another thing that looks like a hospital for another 5 days. The real point of the paper is, if you look in the middle, is the cost of patient care if they get major complications. So if you look at the light brown bar and the dark brown bar, one is surgery in America is expensive. It's about $20,000+ to have elective colorectal surgery if it goes well. But if you have a complication, it almost doubles the cost of that. Now, it's a lot cheaper to have surgery in the NHS in the United Kingdom, but the relative impact on the cost of care is the same magnitude every time we look at it. So on average, a major complication in the NHS costs us somewhere between about 5,000 and 10,000 UK pounds. Now that's the whole spectrum from multiple organ failure all the way through to simple wound infections, but it's very, very expensive. The other thing is the so-called opportunity costs in the light blue and the dark blue bars. That's the impact of length of stay being longer than expected, because that has a log jamming effect. So that's not quite as impactful in the NHS, it doesn't more than double it, but it is impactful. So why is that happening? Why is in 2016 a place like Johns Hopkins, which has more resources than we could ever dream of in the United Kingdom, having pretty shoddy results by their own admission? They're not good results. Well, Professor Henrik Kellett, who's regarded as a sort of father or grandfather of these enhanced recovery principles, which I know you practice here, has been telling us since the last century that it's because we've been practicing traditional methodology, traditional perioperative care methods, that harm patients. There's an editorial I was lucky enough to write with him, saying, why is the high-risk surgical patient still at risk? And in that paper he points out that back in 2008, the mean length of stay for colorectal surgery in the United Kingdom was about 10 to 12 days. That's the average length of stay. It was about that across Europe in 2008. Whereas he's been telling us since the last century that he can get everyone home in 2 days, irrespective of the type of surgery. He says to people, very challengingly, he says all surgery should be day case surgery. They might have to stay till tomorrow or the day after, but almost no procedure do they have to stay for a week or two. And the reason there's a big gap between the two is because we've been doing things that are not evidence-based that hurt the patients. So iatrogenic harm caused by traditions and variations. That's the difference between traditional care and enhanced surgical recovery. Well, that's quite a difficult thing to accept. You would say, well, look, traditionally back in 2008, you were putting nasogastric tubes in patients and leaving them in patients because they were having a bowel resection. We've known for a long time that that's not good for them, it hurts them, and it increases their rates of morbidity. It doesn't protect the anastomosis, it doesn't protect the patient. And we know that consistently. So you keep doing that, us in the UK, you get up in the morning, you pay money for the nasogastric tube, you hurt the patient and you make things worse. And that's what you do deliberately every day of the week. And I said, well, don't pick on me, we're all doing it. He says, yeah, but you should stop doing it. Now, we listened to that for years, and our excuse was that he came from Scandinavia. And Scandinavia is full of blonde-haired, blue-eyed, beautiful people who eat raw fish and ride bicycles and do as they're told. It's not like that in London. In London, we have lots of ugly, fat people who drink too much, smoke too much, and won't do as they're told. So we said, well, it's never going to work here in London, this enhanced recovery stuff you're telling us about, this paradigm shift for doing things wildly differently, for not having the nasogastric tube, for letting people drink and eat straight away, for letting them have their supper in the recovery area after they've had a bowel resection. It's never going to happen where we are. Well, in 2008, 2009, we had a big wake-up in England, and through much of the world we had a global financial crisis. So our National Health Service, along with our country, went broke. As a result of that, we had to have massive savings in the healthcare system, and as part of that, the government turned around and said, we really probably should try this thing, because if it does work, we're going to save a whole load of money, and we're going to have a lot more beds to use, and things are going to get better. So in 2009, myself and Alan Horgan, who's a surgeon originally from Ireland, now working in the northeast of England, were appointed as national clinical leads to roll out a so-called Enhanced Recovery Partnership Programme. That was in 2009. We were given a team, a data management and change management team, and we were given the remit by the Department of Health to say to everybody, you've got to give this a go. And in the first instance, we were told to try colorectal surgery, the major joint replacements, because they're the second biggest bed users, major cancer gynae surgery and major cancer urology surgery. Now we had the data on everyone's outcomes, so we knew that there were about 60 hospitals out of our, let's call it 200, who were already doing enhanced recovery, and they had fantastic results. Our challenge to the country was for the whole country to be as good as the top 10% of providers were at the beginning, because that was an achievable goal. We were allowed to write to every chief executive, myself and Alan and the team, and say, you've got 2 years to try this enhanced recovery thing. If you try it and it doesn't work, we'll help you, we'll give you guidelines, we'll give you support, we'll give you recipes. If you try it and it doesn't work, then we'll work with you to understand why it didn't work. Because at the very least, we'll get a publication out of that. Because nobody who's tried it properly has failed to get a return on investment in a financial year. So we said, you chief executive not trying this would just be crazy, because you're leaving millions of pounds on the table by not trying it. And then we added a little twist to that in the final paragraph. We said, if in 2 years you haven't tried it, it's okay if you tried it and it didn't work, but if you haven't tried it, we're not sending you any more surgery to do. They said, oh, run that one by me again? I said, we're not sending you any more surgery to do. No, you don't mean that. We mean that. If you don't try it in 2 years, we're not sending you any more joints to replace. Oh, they said, okay, that's interesting. So everyone tried it. So within 6 months, we had 85% of the hospitals in the National Health Service trying enhanced recovery. Our goal was to have total adoption within 2 years. It took us 3 years to get to a point whereby we'd moved the needle such that the length of stay for the whole country was as good as the top 10% at the beginning. And all those sort of principles, like no nasogastric tubes and drinking and eating immediately post-operatively, rapidly just became normal, which is very interesting to watch. So the length of stay for the whole of the country of England, this is just some examples here, this is not cherry picking, went from these sort of durations in 0809 for every single procedure in the country. This is not saying you're on an enhanced recovery program. We didn't say that. We said this is all in, is how we will judge ourselves. To these sorts of levels in 1213. So our joint replacements on average for the country by then were staying 4.5 days. Now many places were doing day case joint replacements by that stage, which is relatively commonplace now, but overall we took 2 days off the length of stay from every joint replacement in the country. That's a massive saving. Saved hundreds of thousands of bed days, tens of millions of UK pounds. Productivity went up, we weren't cherry picking, quality went up, morbidity rates dropped, long-term cancer survival rates improved, patient satisfaction went to the highest level ever. So as opposed to people thinking they'll hate being kicked out of hospital early, benchmarked against our national survey, the patients were the happiest they have ever been. And the reason why they were happy was because of information and empowerment. And most people actually want to get home. There's some people who don't. They say, can I stay here a little bit longer? Nurse, doc, it's quite cosy, it's good, beautiful people to look at, you're feeding me. But most people want to get home. And overall we reduced cost, such that by the 30th of April 2012, a declaration was signed in public by our healthcare leaders that said enhanced recovery will now be standard practice. So the President of the Royal College of Surgeons, the Royal College of Anaesthetists, nursing, everybody in public signed a declaration, such that after that point, if you went to medical school, you only learnt those principles. So my son trained as a doctor after this, he's now completed his training. He's only ever learnt those things. He's never learnt the crazy keep them starved, wait for bowel sounds nonsense that we made up, etc. He's only learnt that no nasogastric tube, drink, eat straight away, mobilise. And if you're a surgeon, for example, and you go to do your FRCA in Lincoln's Inn Fields and you say, I'm going to leave a nasogastric tube in because they've had a segmental bowel resection, I'm not going to feed them until they get bowel sounds, you just fail. Off you go. Wrong. Bye-bye. So that's great. The whole country changed very, very rapidly. So what are the... You do a national leadership role, people say to you, well, how do you know people are doing enhanced recovery? And what's the secret sauce? Well, how do you know they're doing enhanced recovery? In my mind, came down to the thing at the bottom here. If you want to know there's a real enhanced recovery program, you ask to go and see yesterday's patients, and if the majority of them are drinking, eating and mobilising, known as living the dream, then that's real enhanced recovery program. Ideally they're dressed in some of their own clothes, not like the other prisoners. That's quite hard to deliver, but that's even better. They're sitting out in a chair to have a chat with you, and they've already been for a walk and they've had their breakfast. That's enhanced recovery. And our national target is for 90% of patients after all forms of surgery to be drinking, eating and mobilising within 24 hours. We're not quite there, but we have been there, slipped a little bit recently. From the point of view of the in-hospital bits, minimally invasive surgery, laparoscopic surgery helps. Smaller holes are easier to manage. But from those of us who are involved in the other care of the patients, it seems to be that pain management and fluid management are the two big ticket items. So so-called multimodal opioid light or opioid-free analgesia and world-class fluid management. And I'll do more on the fluid management in a second. If you don't achieve those two goals, so if you've got somebody who's hypovolemic or overloaded, who's had too much morphine on board, who's now sleepy and feeling sick, you can't get them to drink, eat and mobilise. Now it's great from team anaesthesia, team nursing perspective, because if you do an absolutely stellar job that matches the great surgery the patient has had, they're ready to drink, eat and mobilise. If you've taken your eye off the ball, it's obvious that you're not very good at what you do. So if your patient's sleepy, throwing up, can't get out of bed because you got the fluid or the pain management wrong, you get a finger pointed at you to say, you might talk a good game, but actually look at that. That can't drink, eat, mobilise. And that gets people's attention very quickly. Here's a typical enhanced recovery program. It's very similar to the one that I've just been looking at here. You are world leaders in this space. You've got a wonderful local enhanced recovery program written up and in action. This comes from Vanderbilt in Nashville, United States of America. If we walk through it from top left to bottom right, it's for elective colorectal surgery. Top line is preoperative, middle line is intraoperative, bottom line is postoperative. Although they still keep people nil by mouth after midnight, something which we've tried to abandon completely in the UK. For fluids, you'll see some publications on this recently. We're going to no NPO for clear fluids is the next move in the UK. Paediatrics has done it already. If they are nil by mouth after midnight, they get a carbohydrate drink beforehand, so they come to theatre hydrated and not hungry. They then start their oral multimodal analgesic meds, and no one's saying that these are secret sauce, but they happen to use gabapentinoids and acetaminophen or paracetamol. A high use of regional techniques, so trying to avoid systemic opioids in particular, PONV prophylaxis, intraoperatively, doing everything possible to avoid the use of opioids. So they happen to use a lidocaine infusion or lignocaine infusion, a ketamine infusion, IV, a non-steroidal. If they have an epidural, they try and run as an infusion or a peripheral catheter. PONV prophylaxis continues. They then have their no bugs regimen. I don't agree with some of those things, but that's what they believe in. They use a goal-directed approach to fluid management. They avoid the use of saline. They don't put nasogastric tubes in. They deliver them, says zero balance here, into the recovery area. We'll come back to that. They happen to use 24 hours of a lidocaine infusion or lignocaine postoperatively for its analgesic properties, which seems to work quite well. They keep the oral meds going round the clock, not just PRN, which includes a non-steroidal paracetamol or acetaminophen and a gabapentinoid. They avoid the use of PCA if at all possible. They only use opioids as rescue. They don't leave a urinary catheter in, and then you don't have to worry about oliguria. That probably doesn't matter. So say don't measure it, won't hurt them. They tell them they're going to drink, eat and mobilise straight away, and they tell them to expect to go home within 3 days. And each day you sit down with the patient and say, we hope you'll go home tomorrow, but if you're not quite right, it might be a couple of extra days. But the goal for the family is 3 days. So we'll talk a little bit about the fluid management. It's been a lifetime passion of mine. Now, the comments I'm going to make here, this is what I say to every room I talk to, is this doesn't apply here, and it doesn't apply to you. It just applies to everyone else and everywhere else, if you're tracking with me. So don't be offended that I'm suggesting your fluid management is anything other than completely perfect. It's just everyone else and everywhere else is terrible at this, including my own institution. So this is from 2 centres in the United States of America. They've looked at 6,000 patients. They've got this very detailed electronic health record, so they can drill down into exactly how much fluid patients got, and then they can look at the factors that might determine how much fluid you get on the day of surgery. So they've asked the question, is it duration of surgery? Is it blood loss? Is it heart rate? Is it urine output? What's the major determinant of how much fluid you'll get? And they found, by looking at 6,000 patient episodes in 2 separate institutions, that it was the anaesthesia provider. So the person who's come along to do the case is by far the strongest predictor. And I know it's not here, I know it's not you, it's just everywhere else and everyone else. Even their very, very best provider was all over the shop. They showed an applied example that a patient weighing 75 kilograms, undergoing a 4-hour procedure with minimal blood loss, could receive anything between 700 mils and 5.4 litres of crystalloid on the day of surgery. Now, our institution is not quite that extreme, but it's quite extreme. It's litres either way, which is hard to understand. Here's another example. Myself and a surgeon, Julie Thacker, got a grant to look at, so this is US data, but they have the data to access to answer these questions of that we don't quite yet have in the UK. We looked at 499 hospitals. This is colorectal surgery. It's more than 84,000 cases. And we've asked the question here, how much fluid can you expect to receive for the whole of your stay in hospital if you have elective colorectal surgery? And 10% of institutions are giving patients 10 litres, so that's 10% of 499 hospitals. Some, for exactly the same surgery, give 1 to 3, and some give 21 to 23. And they're all right, and they're all doing the right thing, which is very, very interesting. So, how much fluid should you give to a patient in the USA having a colectomy? An evidence-based answer is 700 mils to 5.4 litres, depending on who's giving the anaesthetic, and 1 to 23 litres, depending on where you got dropped off for your surgery. And that is an evidence-based answer. And that is reproduced in the literature the whole time, and it's reproduced when we do local audits, regional audits, national audits. Now, how can that be so? And if it is so, it can't really matter, can it? Because we wouldn't accept litres here and litres there. We wouldn't accept that for glucose or oxygen levels or blood pressure. So why do we accept it for fluid management? And traditionally we've told each other, don't worry about it, it's just a few extra litres of saline. It's just a few extra pints of water. Surgical colleagues would say to us, it's not just a few extra pints of water, it's also quite a lot of salt that you're giving. And salt is the real enemy. If we look at a bag of normal saline, for example, we were joking about this earlier. If we look at a bag of normal saline, and Hartmann's is close to this in its salt content, it's not quite as high, but it's close. A litre of saline is 0.9% solution. That means there's 9 grams of salt in every bag. Now remember yourselves that your dietary salt requirements are about 3 to 5 grams. So let's imagine that's about 2 days of salt. So every extra litre a person gets is 2 days of salt they don't need. That's the crisp or potato chip equivalent of 25 bags of those types of potato chips or crisps. Now you'll have different potato chips available. I encourage you to look at them and calculate how many bags equals a litre of saline. Some of ours in the UK it's 30, some of them it's 18, but it's a lot of salt that you're giving a patient. So in UC Irvine or Vanderbilt, where they gave 4 litres the patient didn't need, they've given them the extra salt equivalent of 100 bags of crisps. That's what you've got to handle in the days that follow. And that's what makes the top of your legs rub together when you weren't expecting it to happen. That's what makes your gut go to sleep. That's what splints your diaphragm. That's what helps you get a pneumonia. That's what stops your wound from healing. And that's why our surgical colleagues don't like us doing that to their patients. So we know what we're trying to achieve with fluid management. We're trying to get the balance between too little and too much. So we know there's harm associated with too little and too much. We know that if we give too little, we underperfuse organs. We know if we give too much, we create edema and problems there. And we know we're trying to hit the sweet spot. And the sweet spot's getting harder and harder to hit. It's getting harder to hit because of elderly patients with polypharmacy, multiple comorbidities, and things like laparoscopic surgery, which is physiologically complicated. Does that U-shaped relationship really exist? Well, here's another example where we've looked at that US database. We've now brought it down to a patient level, and we've asked the question, if you look at real data, is there a U-shaped relationship? And here we see over 600,000 patients, and if you look at the big picture, there does appear to be a U-shaped relationship. I'll walk you through that a little bit more slowly. So on this slide here, there are just under 85,000 elective colon patients and over 500,000 hips and knees. I've divided the amount of fluid on the day of surgery into quartiles. So in the middle is 50% of the patients. So 50% of the patients having colon or hip or knee surgery are getting about 3 litres of fluid, and currently that seems to be about the right number. And it's a broad generalisation, but ballpark, that seems to be about right. However, 25% of the patients are getting more than 5 litres during colon surgery and more than 4 litres during hip and knee surgery. So we're going to call that the sweet spot, and we're going to call that liberal. At the other end of the spectrum, there's a group of patients who are getting less than 1.7 litres for colon surgery and less than 1.25 litres for a joint replacement. That seems a bit mean to me. I'd be worried that they are dehydrated or hypovolemic. But now let's do a comparison at a per patient level of these 600,000 patients. And when we look then at, for example, cost is higher in the drier or the wetter group. So the 25% who are in the drier group, cost is 15% higher. In the wetter group, it's 30% higher. That's a lot of money, purely associated with the amount of fluid. If we go on to look at sweet spot, liberal, restrictive. If we go on to look at ileus, for example, because some people think that running people wet causes ileus. But also remember, running people dry causes ileus, because the gut hates being dry. It really, really hates being dry. What you want to be, like most things in life, is just that moist bit in the middle. Not too dry, not too wet. The Goldilocks experience. Actually, ileus is more common if you run patients dry. This is a typical hemodynamic framework that you'll find in most guidelines now. This happens to come from the Perioperative Quality Initiative, www.poqi.org. They've done 6 different initiatives now. This is from the first one, and in the first one they've looked at multimodal pain management but also fluid management. And on these 3 different infographics here, the right hand side one is the whole patient journey, the left hand side one is choosing which patients for which monitors, and the middle one is a hemodynamic algorithm that I'll come back to. Now, mixed in with all of that, blood pressure is the new kid on the block. So we're worrying about too much fluid, we're worrying about too little fluid. We think we've always worried about blood pressure, but it's now time to probably worry more about it. Again, based largely on large observational studies from the United States of America, it seems that as little as 1 minute of a mean arterial pressure of less than 65 millimeters of mercury perioperatively is associated with an increased risk of death, stroke, heart attacks, kidney failure, etc., etc. Now, most people are going to get away with it, but if you do get one of those problems and you look back and there was a period of hypotension, the lower it goes and the longer it goes on for, the worse, the bigger the association is. It's a bit scary that most of that harm has been observed between induction of anaesthesia and so-called knife to skin. So that window where traditionally we haven't worried about the saggy blood pressure is where the biggest signal of possible harm is coming from. Now, there is one interventional study which is purely focused on this issue. It's a French multi-centre study from a gentleman called Emmanuel Foutier and colleagues who did a lot of the lung protective ventilatory strategy studies. So it's 6 centres in France, based out of Paris. They've randomised 300 high-risk patients who were hypertensive preoperatively undergoing major intra-abdominal surgery, and they've randomised them to standard of care, which has some blood pressure thresholds where you would give a shot of metaraminol or something, compared to the infusion of peripheral dilute noradrenaline in the interventional group. After induction of anaesthesia, they start the noradrenaline infusion and keep the blood pressure within 10% of their baseline blood pressure. And as a result of that, they have quite dramatically better results. So this is a composite outcome variable with a probability of post-operative organ dysfunction. The p-value separating the two, the lower line is the individual treatment, is the better place to be. The p-value is less than 0.002. Now when you read this paper closely, the thing to note is it's not just a vasopressor infusion. For those of you who know this area well, giving an exogenous vasopressor to somebody who's slightly hypovolemic is disastrous. It's disastrous to splanchnic perfusion, it's disastrous to the kidneys. If you're euvolemic or ideally slightly hypervolemic, it's an okay thing to do. Do it to somebody slightly hypovolemic, it's potentially disastrous. They measured cardiac output in all of their patients, which is a standard in France, they say, and they gave fluid boluses to optimize stroke volume and therefore intravascular volume before they gave the vasopressor. So it's volume, then flow, then pressure, not just pressure. Here's another trial, which superficially looks different, but actually when you get into the detail of it is exactly the same. We're now switching over to Spain. So this is the so-called Fedora trial. It's again under this guise of goal-directed hemodynamic therapy, looking at low to moderate risk patients. Most of them are actually colorectal patients, but there's also some major gynae and major urology in there as well. It's a 420 patient multi-center randomized controlled trial. And in this algorithm, they've measured cardiac output, and they've looked at stroke volume, cardiac index, and mean arterial pressure. They've given fluid boluses to optimize the stroke volume. And then only after that have they said, is the mean arterial pressure and the index okay? Left-hand column. If it is, carry on. That's 75% of the patients. If the mean arterial pressure is too low, but the index is okay, start a vasopressor. That's 25% of the patients. And the right-hand one is, do they need an inotrope, which is almost no patients. Sorry, this is a bit of an eye chart here, but I've highlighted the major results for you. The top line is major complications. So the little dot going to the left of the line means that it's improved with the intervention. All the dots are either on the line or go to the left. The ones where the little wings don't touch the line means that they're also independently statistically significant. So complication rate goes from 16.6% to 8.6%. There's less acute kidney injury, less acute lung injury, all statistically significant, less cardiopulmonary edema, less pneumonia, and fewer surgical site infections, both superficial and deep. And those outcome variables are recurrent through all of this literature. It seems to be that things related to the perfusion or underperfusion of the GI tract, which subsequently can have knock-on effects with those type of complications, come to roost around day 3 post-operatively. So final thing is, why not just restrict? We've had this global blight for the last about decade of people thinking somehow that there was some literature that suggested that restricting people's fluids perioperatively improved outcomes. That literature is undiscoverable, and there is no biological plausible reason why running somebody dry would benefit them. The actual word restriction, which was brought into play by a surgeon from Denmark called Brigitte Brandstrup, was stopping grossly fluid overloading people. So the R word was, rather than having them 5 litres positive, try and give them less fluid. And she subsequently changed her language to be zero balance. In the meantime, and it's happened globally, people have started to turn around and be fearful of giving perioperative fluids. So they've abandoned the sort of litre of fluid around the time of induction of anaesthesia. They've abandoned the understanding that patients are dehydrated before they get to theatre. They've abandoned the idea that bowel prep might be making them hypovolemic and dehydrated. They've somehow abandoned all those things in some places. Now, a simple restrictor's view of life is, well, I now only give 1 litre of fluid and I give vasopressors, and my patients look great in recovery and they go home quickly and they breathe well. All true. The trouble is the silent killers come to get them in the days to follow once that bit's all gone. So that gives you the warm fuzzy feeling if you're a restrictor. Here's an example from the Mass General Hospital, another shiny North American hospital, where, having seen our data on those 600,000 people, looked internally to say, well, we're the Mass General Hospital, we're the most famous hospital in the world. That won't happen here because we're the Mass General Hospital. So they looked at 92,000 of their own inpatients, divided the amount of fluid on the day of surgery into quintiles, and I'll take you through slowly in a second, and found this U-shaped relationship in their own institution. They found that if you look at 30-day mortality, so as you go from Q1 to Q5, the right-hand group, Q5, are the wettest patients on the day of surgery. They're the ones with the most positive fluid balance. The ones on Q1 are the driest patients on the day of surgery. Now, we'd all believe that the wetter patients would have a worse outcome because they should be the long ones, the bleeders, the problem patients. But if you look at the driest end, there's a possible uptick in more mortality there as well. Go on to post-operative respiratory complications. So if you like the lungs to be dry and you like people to breathe well and not worried about the rest of the body, then you're right, because the drier patients breathe better post-operatively, the wetter ones have more pulmonary complications. Length of stay is longer in the wet or wetter patients, but cost is actually highest in the driest group. Why? Because they go on to get the silent killers. And in this example here, they've chosen acute kidney injury to look at, so disturbingly high rates of acute kidney injury in the driest group. We now have the world's largest prospective randomised controlled trial, the RELIEF trial, which is run out of Australia, but it's an Australia-New Zealand-led trial. 3,000 patients, conducted, led by Paul Miles out of Melbourne, with the hypothesis that running patients a little bit drier at the time of surgery would improve their outcome. So he thought and believed for a long time, by his own admission, and listened to it on Top Med Talk, that running patients a bit drier, they'd have improved disability-free 1-year survival. And he did not find that. There was no benefit from being, and this was zero balance, they weren't actually run dry, they would just run right on the money. There was no benefit at all, and actually there was statistically significant harm, not only from sepsis and wound infections, but acute kidney injury, consistent with all the observational data and consistent with first principles, was statistically significantly higher in the drier group, such that the moderately liberal group, i.e. +1 to +2 litres at the end of surgery, had the better outcomes. So I think we can say with the greatest confidence possible at the moment, based on the biggest ever trial, that fluid restriction is bad and we should not do it to our patients. It's got no plausible physiological basis. There's never been any evidence of any benefit in the literature for it at all. So if you are still doing it, please stop, would be my advice. Now, in this paper, I don't know if you've discussed this in any journal clubs, is the so-called New Zealand effect. So for some reason, and some people have told me, steady now, this is the Auckland effect, okay, which I'm going to next. This is you're extreme outliers in as a country in demonstrating the fact that the liberal group did way better in this trial than the restricted group. The hazard ratio, for those of you who are not very familiar with hazard ratios, is 5.6. That's a huge effect, and the p-value is 0.007. If you have any theories on why that may be true, then please don't hesitate to share them. Actually, I think most of these patients were recruited from Auckland, and maybe they'll be able to explain it to me. So let's try and put those 3 trials together and finishing. The top one is the FCAI study. That's the noradrenaline infusion given to keep the blood pressure up during surgery, having measured cardiac output and having given fluid boluses and then giving the vasopressor infusion. Interesting to note, noradrenaline infusion, producing a better outcome. The FEDORA trial, which is measure cardiac output, correct volume, then correct flow, and keep the MAP above 65 with a vasopressor infusion. And then the RELIEF trial at the bottom, which is, if you're going to guess as opposed to measure, then guess moderately liberal. So at the end of the case, land your patient about +1 to +2 litres, not zero balance, which is now associated with harm and doesn't appear to be enough fluid. That's a bit of a paradigm shift for some people. If you overlay those 2 trials, which sets up a question, doesn't give you an answer, but the blue bars here are the restrictive group and the liberal group in the RELIEF trial, with an AKI rate of 8.5% going down to 5%. With the FEDORA trial, which is the proactive cardiac output management, volume, flow, then pressure, the AKI rate goes from 8.5% down to 1.5%. So I think the red bars is current state of the art, and we should be aiming to have 0% post-operative AKI, because it's probably completely avoidable the iatrogenic harm having post-operative acute kidney injury. And if you do get it, less than 2% is sort of a stay a bit relaxed, but higher than that, not good. I'll leave you those 2 websites, evidence-based preoperative medicine.org if you want to come to one of our meetings, topmedtalk.org or .com, both will get you in if you want to listen to our meetings, and we'll send you a podcast every day. Thank you for listening. I always wanted to come to Rotorua when I was here. Now I've been, I want to come back. So thanks very much for listening. I'm delighted to take questions. Or comments, please, if you want. If you see life very differently, go for it. Do you want the lights up for a second? Yes, sir.
Monty, thanks for an awesome talk.
Aren't you that chap who's in that team that's top 10 in the world for extreme?
Oh, not
Yeah. I'm humbled. You should be up there giving an interesting talk. Yeah.
I want to ask you about post-op ward care
Yep.
of bowel surgical patients. you know, ever since I was a house surgeon, and that was quite a long time ago, assessing fluid state on the ward post-operative, it has been very hard. With the advent of ERAS and the use of cardiac output monitors, I think that game is changing, but we are yet to have, I guess, embracement of use of cardiac output monitors on the surgical ward. Do you think that either an arterial line or clear site cardiac output monitor is the way forward for ward-based bowel resection patients, and is it reasonable to run peripheral vasopressors in that setting, in a ward-based setting?
I think in a general ward-based setting, probably not. I tell you, our philosophy and approach to this is, one is, if you on an enhanced recovery program and everything's gone really, really well, you should be trying to get the IV down in recovery. You should try and get them out of recovery drinking with no IV running, because they're 2 litres up now, and if they can drink water, they should be fine. And as you say, no one anywhere in the world is really good at post-operative fluid balance. Okay, it's really, really hard to do. It is rocket science, and even the best person in the world is not very good. They might think they are, but they're deluded, it would appear. So it is really, really hard. So you can't blame the junior doctors and the junior nurses at the bedside for not necessarily landing it on the money. Your best chance is to stop IV fluids and get the patient drinking. If you can't do that immediately, try and limit your post-operative fluids to something that is more salt poor, and try and limit the number of bags of that, which we try and do institutionally, to 2 litres. So right up 1.5 to 2 mils per kilo per hour, with a maximum of 2 bags of D5 half, and then aim at the ward round the following morning that they're eating breakfast and drinking to get that IV down. Now, then if that's not happening, those patients are broken. So if the patient who needs the 3rd bag of fluid, or has now got increased losses, or a requirement for resuscitation or replacement, they're broken, and they're now very high risk. So if you look at if you have done all the other bits and you filter out that group, having tried to get everyone's IV down, that group's now identified itself as very high risk, and it probably needs higher care environments. It needs a team that has more time, the cleverest people possible with the monitoring, to try and fix that person and keep them well. And it's really hard. Now, with a good enhanced recovery program, that's probably going to be 1 in 20 people, if you see what I mean. So it's not a big workload, but the 1 in 20 is where all the misery and the hurt and the harm is. So I think that's where you put your monitoring back on, or you haven't taken it off, and that's where you bring them to HD or ITU, and that's where you invest in trying to fix them as quickly as possible. But it is, I know there's always someone who thinks they're really good at fluid management. I'd love to meet them. I've never seen it, and I've never met them, because it is really hard. I'm sorry if you're here in the room, I don't mean to offend you, but well done you. I think I'm really, really good at it, and I'm just not that good. Yeah.
I'm Kim Post, I'm one of the anaesthetists here. Do you think you can individualise your fluid strategy to some extent?
Yes.
I do some bowel resections here. I tend to ask them beforehand, have they managed their carbohydrate drinks? How much have they drunk with the bowel prep? Do they feel thirsty? Are they dizzy when they stand up?
Yep.
Most of them, unless I've got underlying poor cardiac reserve, at induction tend to behave as if they're effectively basically euvolemic,
yep.
And I tend to run a little vasopressor because I run a lot of TIVA.
Yep.
In those patients, reasonably robust, we have some young ones, could you be a little bit more, like as in a litre and a half rather than 2? Do you individualise it at all, or do you think? So
there's a lot there. One is, we were talking about this earlier, I think if doing a preoperative delta weight is very, very useful. So if because your water and salt loss is directly proportional to your kilograms lost beforehand. So doing the reference point of when they were seen a few days ago compared to if they had been bowel prepped, compared to the post bowel prep weight is very informative. Some people are 1 litre down, some people are 6 litres down if you're still bowel prepping, so that's worth knowing. Then of all those other things, yes, I agree with you, but I would always give the extra volume. Based on work in the laboratory, on large animal models and on humans, giving an exogenous vasopressor to something or someone who is slightly hypovolemic is disastrous for the splanchnic bed. So I would say, even though you're kind of thinking they were euvolemic before I put them off to sleep, you've now changed the physiology fundamentally. The anaesthetic agents cause a degree of vasoplegia, they cause an autonomic disturbance, and you put positive pressure in the chest, which makes your heart and lungs think you're centrally hypovolemic. So I think until someone proves differently, I would always give them that first litre. Always give them that first litre, because that's the zone, it would appear, reinforced by the evidence, the zone of safety is +1 or +2. It's exactly the same in day case surgery, for those of you who know the 20 plus prospective randomised controlled trials in day case surgery. 2 litres of Hartmann's is associated with an improved outcome for very similar reasons.
And using the new protocol in terms of a fluid bolus at induction is reassess the cardiac indices. If there's 0 shift with a 250 bolus, would you still empirically give a litre and then continue?
I would.
Does it influence you?
I would.
Yep.
And I just think that's state of the art at the moment. I think it makes sense from first principles.
Yeah.
And any sort of fear that the couple of litres is going to hurt anyone, the evidence has tipped towards the couple of litres is going to help the majority of people. Now, the 3rd litre is when you start to get into trouble. If you're +3 and above, you're starting to bring problems to the patient. And the problem often comes is if you carry on salt-rich fluids post-operatively, then you've done wonderful work, if you see what I mean, and now they've had 3 more litres of salt-rich fluid, and then another 3 litres of salt-rich fluid, and now they're getting iatrogenic oliguria at night, and now they're getting more litres of salt-rich fluid. So, more comments, questions, yes sir?
Do you think there's any role for low sodium fluid infusion?
I think it's tricky in theatre, so I'm not convinced of that. But post-operatively, I think there is. If you land somebody +2 litres, which is the sweet spot, it would appear, they've got 4 extra days of salt on board, roughly. What they then need is free water to be able to not feel thirsty and pee that out. And we changed our guidelines to that. It was a difficult change because people were worried that everyone was going to start fitting from hyponatremia. But we said, hang on a second, go back to your first principles. 1 litre of 5% dextrose can only drop your serum sodium by 1 millimole, if you think it through. Therefore, 2 bags, which is what we cap it at, of D5 or D5 and a bit, is a safe thing to do. If they need the 3rd bag, our local rule is they're broken. Assuming the 3rd bag means sick. So if they really need the 3rd bag, call an expert. But intraoperatively.
On post-op day 1, is it?
Day 1, yeah. So in other words, our institutional guidelines say D5, 1 mils per kilo per hour to a maximum of 2 litres can be delivered by junior house staff or rolling by the nurses. If they need to increase that rate, they can follow our national guidelines, which is Hartmann's solution in boluses for replacement or resuscitation. Both of those are capped at 2 litres. So if they need the 3rd litre, they have to call an expert, because that should be rare that they have to need the 3rd litre with fully embedded enhanced recovery. And once they're broken, the fluid management is rocket science. So if the intensivists are finding it hard, you can't expect the poor house surgeon to be great at it. Yes, ma'am.
Is there any signal of benefit to using peripheral dilute noradrenaline over, say, a pure alpha, in terms of we've been chatting about that as a department just in the last week in a different context, but in terms of splenic, is there any sign to recommend it?
So the question is about metaraminal infusions compared to peripheral noradrenaline. It's a very hot topic, this. We don't know from appropriately designed large prospective randomised controlled trials. What we can say is the FCAI trial used peripheral noradrenaline infusion, and working from first principles, it's got a bit of beta in there. It's not just pure alpha. It's a naturally occurring substance. It would appear to be a pretty smart move. So I think a lot of people are shifting over to dilute noradrenaline, waiting for the answer. I think if the answer comes back and says metaraminal is equal and is safe, they'd have a rationale to switch back to the metaraminal. All they've got at the moment is one trial that used peripheral noradrenaline. Now, we collectively, globally, in most centres appear to have an irrational fear of peripheral noradrenaline. There's no reason that you can't give it peripherally. There's nothing in the package insert. We appear to have made up the central line ITU paradigm. We can't work out where it came from. Most of us seem to believe in it. We probably should knock that on the head and accept the fact that when someone pulls their car out in front of you, your peripheral vein seems more noradrenaline than you're going to give them, and it doesn't seem to make our arm drop off. If it escapes like any drug and starts to do tissue damage, then shame on us. But so I think a lot of us are trying to see, as happens in, there was a a not insignificant minority of centres where giving peripheral noradrenaline is just a non-issue. So I'm not sure how we as a community got here, where, like my institution, you've got to go to ITU and have a central line, which we're trying to change that, because it's just made up. What's it here? Central line, ITU? No? Some people give it peripherally anyway and just don't tell anyone. They put
The anesthetics department here doesn't do that.
We have colleagues who don't do that either, honestly. Yeah. Any more comments or questions? I don't know how long it's on.
I'd say at a former institution it was a little bit of adrenaline and your phenylnephrine.
In the yep. Slip it in there and it works fine.
Do any of the nurses from the ward have feedback or comment? Because this is a fantastic opportunity, because they're as much of the ERAS as the anaesthetists and the outreach nurses. We've got good representation from all of you here. So if any of you have got any feedback, it would be really useful. No?
I think it's food for thought, and we'll be probably looking a little bit harder at some of our day one ERAS patients and our fluids, which we do anyway. But from an outreach perspective, I think we'll have a lower threshold. We've given this much fluid, we need to be discussing this.
Yeah, and I think it's something that I've certainly taken a lot on board from what Monty has said to me this morning, that I'll certainly be reviewing our fluids again, and it's been a progress in place in the last year, and I think I've got quite a lot more guidance, so hopefully we'll get things up and running. But I think what we need to do is try and be as proactive as possible. But the whole point, I think, of ERAS is it's not just one area, it's everything that's really important. And it's, from the start of when they're seen in clinic right through to the day that they get discharged, and it's trying to make it all work together. So, I've certainly benefited hugely from Monty's visit today, and hopefully we'll get things tweaked and changed too. So, personally, I'm very grateful for his talk, and I think thank you very much.
And there's just one last thing I'd say, if I may. I think you're at a stage now, don't keep looking to other people for solutions. You're ahead of the game.
Yeah.
So make your own tweaks and see what works locally, because there's no right answer.
Yeah.
There's just keep tweaking, and you're well ahead of the game.
Good.
So well done.
So can we give him a very big thank you?
Well, I was just thinking, do you think then before they leave Paku, they actually should have a bit more explicit instructions and parameters? Because it's often